Okay, good evening, everyone. I'm Dr. Larry Robinson, our CMA president. Thank you for joining us for tonight's presentation. As you know, physician burnout is an epidemic. The Mayo Clinic released data in September noting 63% of physicians are experiencing some sort of burnout, which reverses the previous declines. It is vital that we work together to support and help physicians who are struggling. Our CMA is committed to supporting physician wellness. As part of our strategic plan, our CMA sponsors a Riverside County Physicians Confidential line that is a 24/7 resource when a physician needs help. It is staffed by trained physicians ready to help anyone who calls. Our CMA has restarted our Physician Wellbeing Committee as a wraparound support for the local hospital medical staffs. Our CMA hosts an annual half-day Physicians Wellbeing virtual conference that is coming up on May 19th. It is a Train the Trainer program designed to assist hospitals and healthcare organizations comply with Title 22 regulations on matters relating to health and wellness, addiction, mental illness, and behavioral issues of physicians and other healthcare providers. Today's presenter is Dr. Barry Bittman, who is the Chief Population Health and Quality Officer for our CMA's sister company, the Inland Empire Foundation for Medical Care. He is the faculty chair for IEFMC's Population Health Management Academy and the nation's first Population Health Fellowship Program. Dr. Bittman is a neurologist, author, international speaker, researcher, population health innovator, who is a recognized thought leader for healthcare transformation. His healthcare initiatives include the development of community care networks and accountable care organizations, as well as the optimization of medical practice workflows and continuous care protocols for physicians, hospitals, and health systems throughout the nations. Welcome, Dr. Bittman.
Thank you, Dr. Robinson, and thank all of you for being here this evening. I appreciate the opportunity to speak with you this evening about a rather important topic that has certainly come to the surface in a big way over the course of the last few years. When we start to look at burnout, we realize that the process is both obvious and destructive. The repercussions are rather significant, and there's a profound impact on all of us. Many physicians believe that the national health emergency associated with COVID was really the triggering factor for the development or the acceleration of this form of burnout. However, we're going to show you that that is not actually the case. So we're going to begin with the facts. When we start to look at burnout from an overall perspective, it becomes immediately obvious that it was present prior to the actual COVID-19 national health emergency. And when physicians were questioned about whether or not they felt burnout before the NHE, 79% actually stated that they were burnt out prior to COVID. Yet when you think about the overall impact of burnout and how it affects our profession and what it truly means to all of us, what's really fascinating is that only 9 to 13% actually sought help. And those are the ones who recognized burnout in themselves. As we start to move forward through this and start to explore this further, it becomes obvious that the definition for burnout has been long established, especially in the context of what we call the Maslach burnout inventory. And it's sort of a triad. It's increased depersonalization, it's increased emotional exhaustion, and it's a lack of personal accomplishment. And from a research perspective, there's a tool called the Maslach Burnout Inventory, which enables us to measure this in not only healthcare providers, but other individuals as well. It's been used for several thousand studies, and the data has been normalized across multiple populations and across multiple languages. I always say if you want to figure out what's inside of a grapefruit, perhaps the best way to do it is to squeeze it. And when you consider what we're facing with burnout, I think that this study really says an awful lot. Approximately 2,500 physicians participated in a study a few years back at the Mayo Clinic. And what they did is they looked at the elements of burnout and they were able to show that mean emotional exhaustion scores increased by almost 39%. And we're talking about the difference between 2020 and 2021. Depersonalization increased by 60%. And overall, 62.8% of doctors reported at least one manifestation of burnout, compared to only 38% in 2020, 43% in 2017, 54% in 2014, and 45% in 2011. So as we start to look back, it becomes obvious that the COVID-19 challenge actually was the squeeze on the grapefruit. However, the juice was already there. And when we think about the ubiquitous nature of burnout and look back through healthcare, I can tell you as a physician for more than 4 decades, I've seen it from the first year of my practice in many of my colleagues. When you look at depression as well, which is often associated with burnout, you see that that increase has been substantial as well. As we start to look at burnout more closely, it becomes apparent that there are a number of factors that come into play. And what I hope to do this evening is really to provide a different perspective. Many of you have probably attended presentations and lectures on burnout in the past, but I want to take a different tact here. I believe that perhaps the greatest factor that comes into play in the nature or the causality of burnout is time. And when you speak with physicians, wherever you are, and within multiple settings, you soon discover that EHR documentation is a major source of contention. It's an obvious factor that seems to be exacerbating burnout. And the shift of time to documentation from work-life balance is really also a major factor, which is especially important in female physicians. And I was reviewing the literature last week, and as I was reading through some of the most recent research, I found this. And this particular paper that was published in 2022 focuses on gender differences in primary care physicians' electronic health record use over time. And this is kind of interesting because what they did is they looked at 2019 to 2022, and they found an increased gap in the amount of time that female physicians spent on the EHR compared to men. And I want you to think about this for a second because it's really important. Women physicians spend on average 7 hours on the EHR for every 8 hours of scheduled time with patients. And that's really ridiculous. When you compare them to their male counterparts, who only spend 5.3 hours interacting with the EHR, you realize that that gender difference is rather substantial. And not surprisingly, when we start to look at burnout, when you add in the additional responsibilities that women have in terms of caring for their families, it's not really surprising that burnout is far more rampant in women physicians than it is in men. If you look at the data and you look at the gaps that occurred over the years, in those 3 years, it was shown that the gap between male and female time on the EHR grew 6 minutes for note writing, 3.3 minutes for inbox tasks, and 6.2 minutes for work outside of work. And when you start to think about that, we're not talking about overall, we're talking about just by the year. So this is rather important when you start to look at time and how time is spent as a factor in burnout. The other thing that I really want you to be cognizant of is that there are multiple causes of burnout. And frankly, I believe that there's also a mismatch. And I call it a supply chain mismatch, but it's actually a mismatch that's far more important, as you're going to hear. When we start to look at what really causes burnout, I believe that the essence of this really boils down to us missing the boat in managing burnout. The bottom line is I think we're trying to force a square peg into a round hole. And everything I read talks about, telling physicians to put more meaningful activities in their life and speak to each other more and try to nurture a sense of camaraderie, which I think is great, but I really don't think it's matching the underlying causality of what's responsible for this in the first place. So I think the best way to look at this is to try to understand the nature of the average physician. And the following strengths pretty much characterize our profession. Docs are autonomous. They're used to doing things alone. They're highly competitive and highly intelligent. They're certainly curious, they're creative, they're achievement driven, and after years of studying, after college and medical school and residency, they find that the activities that they wind up spending most of their time in are inconsistent with their strengths. And not surprisingly, they have an awfully rough time with this. And add to it the fact that they're so independent that it's really difficult to collaborate and come up with solutions. One of the people who have commented on the value or the four magical traits needed to succeed at Apple is Tim Cook. He's the CEO. And he described success in terms of ability to collaborate, creativity, curiosity, and expertise. And I certainly think we have three of those four things. I think physicians today are learning to collaborate. And I think that as you see through this presentation, the bottom line is that one of the antidotes for burnout is team-based care. When you start to think back over your life and your training, you have to go back and think about sacrificing and striving to get into medical school. That was not easy. You had to give up a lot to put in that extra study just to get there. You had to beat intense competition for the best residency programs. And finally, you got into practice with this idea of saving people, saving lives, and becoming a healer. And you were left seeing 30 to 40 patients a day, 80% of whom actually don't need to be seen by a doc. And what I want you to do is consider the fact that here is a very idealistic person who becomes a physician, and then they realize this is a fait accompli. This is what they're going to face for the rest of their lives. And I think that's one of the major issues that actually creates that first sense of burnout. I'm fortunate because I run a population health fellowship and I get to work with young doctors. These are physicians who have just completed their residency programs. And when you read through the literature, it becomes blatantly obvious that burnout occurs within 5 years of practice. However, when you speak to our fellows and when they've had reunions just a year after finishing their residency, they've come back to me and they've told me that while they're excited about the challenges of population health and the growth that they've achieved over the course of the year, many of their compadres are actually burnt out. And many of them feel that they no longer want to be in medicine. And I think that's a shame because it occurs so early. This is a story that I remember reading when I was in, I think it was high school. And I don't like reading slides to you, but I'm going to read this one because it really stuck with me over the years. It's called Animal School, and it was written by Leo Buscaglia, who is often referred to as Papa Buscaglia. For those of you that have some gray hair, you probably know the name. But it goes like this. The animals got together in the forest one day and decided to start a school. There was a rabbit, a bird, a squirrel, a fish, and an eel, and they formed a board of education. The rabbit insisted that running be in the curriculum. The bird insisted that flying be in the curriculum. The fish insisted that swimming be in the curriculum, and the squirrel insisted that perpendicular tree climbing be in the curriculum. They put all these things together and wrote a curriculum guide. Then they insisted that all the animals take all the courses. Although the rabbit was getting an A in running, perpendicular tree climbing was a real problem for him. He kept on falling over backwards. Pretty soon he got to be sort of brain damaged. and he couldn't run anymore. He found that instead of making an A in running, he was making a C. And of course, he had always made an F in perpendicular tree climbing. The bird was really beautiful at flying, but when it came to burrowing in the ground, he couldn't do so well. He kept on breaking his beak and wings. Pretty soon he was making a C in flying as well as an F in burrowing, and he had a hell of a time with perpendicular tree climbing. While Buscaglia was clearly focused on the educational system, the moral of the story applies to us as well. It's often impossible or even self-destructive to set out to do what we're not cut out to do. So when you take a group of creative, dynamic individuals who set out to become healers and to live that life of the physician that they spent their life imagining, and suddenly when they're spending 7 hours a day out of 15 total hours of work doing documentation, I think that's where the problem really begins. As we start to explore this further, it becomes apparent that the problem is highly complex. And I had the wonderful opportunity this past year to write a book called The Patient Who Swallowed a Mouse with my co-author, Dolores Green, who's one of the brightest people I've ever worked with. She's the CEO of the Inland Empire Foundation for Medical Care, where I serve as Chief Population Health Officer. And while I'm not going to read the book, I thought that I could share a little bit about it for you because we basically wrote it in view of the fact that over the course of the last few years, there were several physician suicides in our region. In fact, one of them occurred in a resident. While the physician shortage, is currently being addressed through new medical schools, loan forgiveness programs, and so on, I really think that most physicians today that graduate from their residency programs are ill prepared for actually running a practice. And we believe that this contributes as well to the problem of burnout. So I'm going to share something with you that comes from the beginning of the book. It's called The Surprise Encounter. Why are you here? I swallowed a mouse, she uttered. And when was your last A1C? I continued. She didn't answer. After several seconds, I looked up and repeated the same question. Still no answer. How can I help you, Joan, if you won't answer? Why should I even bother when you're not listening? She responded nonchalantly. What are you talking about? I asked sternly. I told you I swallowed a mouse, and that didn't even register. You told me what? I told you I swallowed a mouse, and that didn't faze you one bit. You didn't even bother to look up from that screen. At least now I have your attention. My what? Your attention, she stated. Remember, you're supposed to be taking care of me. Now, you're probably looking at this and you're saying, this doesn't happen in the real world, but it actually does because we spend more time looking at the screen than we do the patient. And I want you to know that I actually saw burnout when I was a pediatric resident in New York. And this was something that I'll never forget as long as I live, because I was so excited to finally get into a pediatric practice and work with a physician who was going to be my mentor. And I'll never forget my first day in that practice. I was so excited to walk in the rooms and see the kids and be able to examine them with this doctor. And it was really a stepping stone in my career. But suddenly I was sort of disenchanted because the physician walked out of the room with me and he looked up and he said, Dr. Bittman, I have a question for you. And I couldn't imagine what it was. He said, did I look in that kid's ears? And it suddenly hit me at that point that this was so rote, so routine, so done on automatic pilot that he wasn't even cognizant of the fact whether he examined that child properly. And that happens today when we're no longer focused on the work that we're really intending to do. The real question is, what does it take to try to mitigate or replace burnout? What do we do when physicians experience a personal sense of failure and they need a new lease on life? What do we have to do to help put back into a physician's life what's missing? And I think this is part of the continuum of becoming a doctor. The first is ensuring the right fit. making sure that we realign goals with clear-cut expectations. The second, which I think we do a miserable job at, is effective mentorship. In fact, being a healthcare administrator, a hospital administrator in the past, I remember the only time that this took place is when we brought in new surgeons. They sort of had to have mentors over the course of the first 3 to 6 months, but we never did that with anybody else. The third one is a biggie, understanding the business. Most physicians today do not understand how they're really getting paid. They don't understand the work. They don't understand the value proposition. And I want you to know that I'm guilty as well, because when I think back over my career as an individual practicing physician, I really didn't understand how the system worked. When I became a hospital administrator, I still didn't understand how it worked. It took me to get to the payer level or the health plan level, where I served as a chief population health officer, to finally see how it fit together. So I think we better prepare our doctors in their residency programs for being able to move forward. And I'm really pleased to say that I was contacted the other day by a highly dedicated young physician who's in charge of a residency program. And she's the first person that's approached me. And she said, we need to build a 3-year population health program into our residency system. So that's exciting. The second thing that's really missing here is leadership skill assimilation and organizational dynamics. Physicians are really good at treating patients. And my belief is that the overwhelming majority of them are doing it for the right reason. But they're not so great at running practices. And when you start to think about it, why should that be a surprise? I can tell you that many practices, private practices, are doomed on day one because physicians don't even know how to hire an office manager. What they do is they come out of the residency program, they've never had any business experience, they sit down and they speak with a person who seems absolutely wonderful, but they don't even know the right questions to ask. And when you realize down the line, 3 or 4 years, that the accounting is not being handled properly, there's no focus on quality, the physician has basically relegated him or herself just to patient care and everything else is sliding, you realize that you didn't even interview the right person. And the problem began on day one when you didn't even consider it a challenge. Finally, I really think we need a proactive strategy to prevent burnout. And I'm so impressed with our CMA because every year they focus on physician wellness. And that's something that we've often not emphasized enough. And that's really critical. And I highly recommend that you attend that conference because it is life-changing. Most importantly, I believe that the antidote to all of this is team-based care. It's figuring out how to work together at the top of your game, including everybody on your team sharing the tasks. And the bottom line here is that if you fully integrate everyone on your team in taking care of the patient, it makes a huge difference. Now, what have we done in healthcare? We've used extenders the wrong way. Our extenders have been used just to increase volume. What we now have to do is rethink that formula, and we have to bring everybody together and understand the role of the MA, the nurse practitioner, the PA, and the physician. And we can work together and support each other as a team. And I believe that that not only improves efficiency, but that actually helps you get out of the office on time. And if you don't establish that work-life balance, if you don't have that built into your career, I can tell you years later, you're going to really wish you would have. Bottom line, it's a win-win. When we come together and start to share tasks and work with patients as a team, everything changes. The value proposition is pretty simple. Because the patient receives improved care, they wind up with better outcomes, and we wind up with less burnout. The team-based impact, based in part on our book, is best exemplified by a chapter that focuses on a physician who's really at the end of his rope. He's practically suicidal. He doesn't know which way to turn. He has no sense of how to put his practice back together. And the book is really about reestablishing that sense of meaning and purpose in his life. And part of it is learning how to spend less time on the EHR, more time with his patients, and more time with his family. And he comments, team-based care replaced my sense of being overwhelmed with a level of confidence, commitment, and focus that had practically disappeared from my life. He proceeded to note, in fact, I'm convinced that the key to our success was an abundance of business and operational acumen that I certainly didn't have at the time. Essentially, team-based care extended beyond the clinical context into the role of management as well. And I believe this is one of the real factors that comes into play in preventing burnout. And that's putting together a team that can handle not only the clinical aspects of care, but the financial ones, and help with that decision-making, and support each other in a way where there's a clear-cut understanding of what you have to do, and an awareness of when you're starting to get into trouble. I can't tell you over the years how many physician bankruptcies I've been aware of, and it didn't make any sense to me at all until I realized that most physicians don't truly understand or take an active and meaningful role in running their offices. And perhaps that's the reason that most physicians today come out of medical school and they join larger groups. So let's talk about some of the team-based burnout reduction strategies that seem to work. And this came out of a review on strategies to manage physician burnout, and it was published in 2019. The first is scheduling monthly provider meetings focused on work life and personal challenges, as well as difficult patient care management issues. This can be done within a practice, or this can be done within a region. When I was Chief Population Health Officer at Highmark Blue Cross Blue Shield's Allegheny Health Network, we had a group of 8 physicians that met every Tuesday morning for 5 years to help work together, solve problems, and improve the healthcare of their community. And I want you to know that that group is extraordinarily dedicated. That hospital became readily aware of the insights that they provided. And one of the physicians who organized that is now the CEO of the hospital. Another thing is realizing that we can't do everything as physician. Offloading non-essential tasks to non-physician staff, including hiring and having medical assistants enter data in EMRs, is really important here. You have a medical assistant who's bedding a patient, they're asking questions, but there's no documentation inside the EHR. So what you're doing is 10 minutes later asking the very same questions and spending your valuable time entering that data. Another thing we have to do is remove bottlenecks to care. Does the physician have to do medication reconciliation? Do we have to look at vaccinations and certain types of data entry, or can it be done for us by a team? Can we build a system where we tee the physician up to focus on the needs of the patient so that when the patient says, I swallowed a mouse, the next question is, well, what was your A1C? I think that as we start to work together, we realize that we can reduce some of the challenges and certainly the time pressure by appropriating more time to certain patients than to others. And when we come together and we work as a team, that type of work becomes impossible rather than the 8 or 10-minute visit, which, as you know, doesn't work for everybody. I think we have to develop a new prescription line to free up the RN staff. How much time is wasted by your nurse or by your PA? Are they working at the top of their game? Because if they're not working at the top of the game, what they're doing is not helping you with the tasks that you need to accomplish. Having clerks instead of physicians track forms, send faxes, using pre-visit planning and pre-appointment laboratory testing. Why do you have to wait for a diabetic to come into your office and order an A1C? Why isn't it ordered the week before the patient even comes in? Why aren't we taking more time to know who's on that schedule so that we can appropriately take care of our patients, save valuable time, and dedicate more of our resources to actually dealing with the real challenges that people face? And when I speak to physicians all over the country, I can tell you that uniformly, physicians tell me that 80% of the patients that they see each day really don't require being seen by a physician. So whose fault is that? How can we better arrange our time? How can we reduce the pressure, and how can we become more effective? And when we start to standardize our workflows, and when we start to build team-based care, you start to see these challenges disappearing. The mitigation of these challenges is based upon the preparation, the planning, the workflows that we built into our routines that make everything work better. The National Academy of Medicine has looked at this as well, and they believe that the real challenge today is not so much what's happening today, but the fact that 40% of nurses, 40%, 20% of physicians, and more than 25% of state and local health department employees are considering leaving their profession. How sad. How sad is it to prepare your whole life to become a health professional and then focus on leaving whenever you can financially do so? And the National Health Plan identifies specific near-term actions to achieve multiple priorities. These priorities, in general, are creating and sustaining a positive work and learning environment, investing in measurement, assessment strategies, and research so we can really figure out what's working and what's not working, support mental health and reduce that stigma. And I want you to know that very few physicians actually seek counseling, despite the fact that we have counseling lines here and throughout the United States that are entirely private. I think we have to take a closer look at addressing compliance, regulatory, and policy barriers for daily work. And when you think about the mother may I, or the permission to order a procedure or a test, and the amount of time it takes away from a physician's life or a practice's time to be able to do those pre-authorizations, you realize that we're really spinning our wheels. And I think Congress is finally realizing, at least I've been reading about this for the last few weeks, that we have to have a sustainable increase in payment structure for physicians. We can't keep facing inflation of 7 to 8% and cutting back on physician fees. And I'll tell you, that's one of the reasons that I really believe very strongly in the Foundation for Medical Care and RCMA, because they're your advocates, not only here in California, but also in Washington, D.C., to promote the well-being and the financial success of physicians as well as patients. And I really believe that finally, if we want to attack this problem and really put a dent in it, we have to institutionalize well-being as a long-term value. How often do you think of well-being of your staff? How often do you think of strategies to help them better cope? What is the day-to-day wear on the people that you work with? And how does that impact their ability to help produce the best patient outcomes possible? And finally, I think we really have to focus on recruiting and retaining a diverse and inclusive health workforce that can make a difference. And frankly, when I'm looking at young physicians today and looking at their knowledge base coming out of residency programs, I'm disappointed. They really don't understand quality. They have very little experience, if any, in understanding how a practice is run. They're really not familiar with the challenges of running a practice or paying a staff. They're really not that great on RAF scoring or HCCs. And when you start to look at their overall performance as physicians, there are certainly a host of deficiencies that have never ever been covered in their residency program. Now, I know what some of you are thinking, that's not the job of residency program or medical school. But frankly, I'm going to tell you here and now, I think it should be. I think we should better prepare our doctors for being better physicians and being able to understand the business of medicine and to be able to mitigate some of the challenges that they're facing. We are really good at what we've been trained to do. But how many business majors do you know become physicians? Just typically does not happen. So we have an unprecedented opportunity here. And it's based upon a very simple formula that I've put together based upon years of experience. And this is the formula that I believe is really the nuts and bolts of preventing burnout. One, we have to improve residency training opportunities. We have to change the curriculum. We have to better prepare doctors for how the system works. And we have to make sure that that transition from residency to private practice or group practice is not like jumping into an ice cold lake. Next, we need to create better leaders. We need to train physicians. We have an enhanced learning opportunity now for medical practices where we work with physician leaders and teach them how to better deal with their physician colleagues, teach them how to be more equitable, teach them how to be more cognizant and empathic of the challenges they're facing. And I describe that as expert, passionate, compassionate leadership. What we also need is true practice transformation. And I'm telling you, you're not going to get it from the Fed, you're not going to get it from the state government, and you're certainly not going to get it from your local health plan. The bottom line is that transformation is a grassroots approach that depends on us to do it. We have to take the initiative. We have to put ourselves in the position of really wanting to change what's going on, not for ourselves, but for our patients. We need to go home at the end of the day knowing that we have a major role in improving patient outcomes and their experiences, and at the same time, controlling the cost of care, and finally, reducing burnout not only in ourselves, but in our colleagues. That transformation has to start with us. And finally, and I don't see much of this at all, because I can tell you that in years past, when I went into practice, every morning, all of our specialists in our community and the family doctors would round, and then we'd sit together in the physician's lounge for 20 minutes. We'd have coffee, we'd talk, we'd discuss challenges and problems. Today, the hospitalists go to the hospital, and most of us don't. And the bottom line is, we're really estranged from other physicians. So what we have to recreate is an interdisciplinary staff cohesion as the foundation for fully integrated team-based care. We have to find people that we can talk to, that we can discuss these issues with, that we can solve problems with, and it can't fall on one person. So the bottom line, a practical antidote for reducing burnout is pretty simple, but we have to take those steps. One, we as a profession have to stop squandering our greatest resources, our people. Our physicians, our nurses, our PAs, our MAs, and we have to really focus on building teams of people that support each other. We have to stop accepting provider burnout as an inevitability. And this is something that really upsets me because I've heard countless presentations where they say, oh, we have to take better care of ourselves, this, that, and whatever, but there's no solution. And when people go back after hearing the lecture, 3 days later, they can't even remember who the speaker was. So they don't put into play what they've heard in those presentations. This is your opportunity to take some of the insights that you've heard tonight and put them in action, not a week from now, not a month from now, but tomorrow when you get back to the office. Finally, we have to realize physicians aren't really good at doing everything. We're not going to do perpendicular tree climbing like the duck. We can't be expected to thrive when half of our time is on the EHR and menial tasks. And I'm not suggesting that these not be done, but what I'm suggesting is that we redistribute the work and establish meaningful workflows that allow us to share in those efforts. And finally, we've got to start working at the top of our game. If 80% of the patients that you see really don't need a physician, you're spending your time in the wrong way. You're wasting your time, and wasted time can never be recovered. So how can you better risk stratify your patient population so that you are seeing the sickest and most complicated patients that actually need professional medical judgment? How can you do that in your practice and at the same time regain a sense of meaning and purpose in your life? I think we also have to focus on formalizing a process of mentoring new recruits. And I don't mean in a hospital, I mean in your practice. You have a new internist or family doctor that joins, or a new neurologist or obstetrician. How do you work with that person? How do you devote a year to mentoring that individual, to taking them under their wing? How do you also integrate their family in the activities of the rest of the practice? Let me tell you this, if the spouse isn't happy, there's no way the doc is going to stay. And often young physicians feel estranged, and they feel like, I came into this and all I've done for the last 6 months is see 30 or 40 patients a day. I don't even get to talk to the other physicians. We have to grow each physician's leadership potential. And the chairman of our board at IEFMC is Dr. Tariq Mahdi, and he has a saying that I absolutely love. And he says this to his staff of over 50 people. He says that each of us is a leader in our own right. Each of us has the potential to lead, to be in charge of something, and to take action, and to do something to improve overall quality of healthcare. And I believe that. I think we also have to ensure flexible spending. Scheduling rather, not spending, but scheduling, because I think we need a breather. Physicians can't work nonstop. I think that we have to focus on putting back a work-life balance that makes sense, that we can thrive on, that our families can thrive on, because you're never going to get that time back away from your children. And if your life at home is unhappy, I guarantee you it will carry over to your work and vice versa. And finally, I think we need to develop programs that focus on physician wellness, camaraderie, and rational work-life balance. And if you're in a practice with multiple physicians, is it important enough to set up one meeting a month where you guys can come together and come up with some novel things that you can do together, or some enjoyable things that you can do to get to know each other better? I can tell you that over the course of the years, I've seen more conflicts among physicians than just about any other group. And what I've discovered as a healthcare leader is that when you get to know the docs, when you get to know the people involved, suddenly people start to get along better. You start to appreciate the other person's perspective. You start to realize where they're coming from. And that sense of camaraderie draws you in. And that's also a sense of not being alone. And it, in many, many ways, reduces burnout. Being part of something is really important. And finally, as I've said multiple times today, instituting team-based care. I know you're probably saying to yourself, you can't afford it. I'm going to tell you right now, you can't afford not to have it. When we talk about quality performance, when we talk about quality incentives, when we talk about building a reputation with the health plans for your organization so you can improve your remuneration, that comes from dedicating the right team to that type of work. And if you do so, I can assure you that you will be paid back in spades. So we can't talk about burnout without talking about financial solvency and doing well and being able to pay your employees on Friday afternoons. And I can tell you that I've been through rough times in healthcare where CMS has decided for a month that they weren't going to pay anyone, and physicians had difficulty meeting their financial requirements. So we really have to find better ways to make certain that we can handle the financial needs of our practices. In closing, I really think that when we look at burnout, we're really looking at the overall wellness and well-being of our physicians. I think it's a horrible tragedy to spend 4 years in college, 4 years in medical school, 3 to 6 years in a residency, and come out and in year 2 no longer want to do it. I think we're squandering our greatest resources. I can tell you that physicians can be challenging, but from my perspective as a healthcare leader, I can tell you that my friends who are physicians are some of the greatest people I've ever met. And they're going through enormous challenges, and they don't have to. So perhaps we can find common ground, we can work together, we can develop a grassroots strategy for transforming healthcare in a manner that actually works. What I can assure you of is that what we're doing today is not affordable and it's not sustainable. Thank you.
Thank you so much, though. What an excellent presentation, such meaningful and valuable information. Certainly appreciate all that. And so let me just jump into these questions here. The first one is, is there early signs of burnout before full-blown burnout occurs? Can you explain more or example of depersonalization?
Oh, yeah, I really love that question. It's absolutely phenomenal. Let me address the first part of it. I think that the telltale sign of burnout is lack of interest in what you're doing. It's lack of fulfillment. It's sitting in your office and not wanting to be there. It's a sense of removing yourself from that decision-making process and not wanting to come to work tomorrow. And I think many physicians who are on the call actually face that. I actually had one physician say to me recently that getting sick was actually a positive thing because that gave her a break from having to go to work. That's really sad. And depersonalization is even worse. It's a sense of, I don't even feel like a human being. I'm a waste. My life doesn't really have any sense of meaning and purpose. I'm not really making a contribution. I always wanted to be a physician, but I'm letting my patients down and I'm useless. And it's hard to believe, but after all the training, all the dedication, all the competition to get into medical school and residency, that 2 years after starting, you can feel like that. But I want you to know it's ubiquitous. It happens all the time. I hope I've answered the question.
Yeah, excellent. Excellent. Appreciate that. Also, how about males versus females? That's a follow-up question for that person.
Burnout knows no difference in sexes, but we're starting to see worsened burnout in females. And I'll tell you why I think that's occurring. When I went to medical school, which was back when the dinosaurs roamed the earth, the schools were predominantly male. Now, more than half of the medical schools are women. And childbearing and family caring is really a task that's been relegated in most cases to women. So in addition to the challenges that they face in their practice, they have scheduling issues. They have to take care of the kids. They often have to take care of their husbands. They often make the medical decisions for the family. And those additional pressures, certainly coupled with that sense of more time spent in documentation, as I demonstrated earlier, it certainly makes burnout more prominent in women, but it's especially prominent in men as well.
Very good. Thank you for that. And all right, the next one has to do with, I think everybody's, thorn in their side is the in basket, stating that Dr. Adams states it's not only the documentation time, it's the in basket time. This leave the time before and after work, lab review, messages, patients based on labs, radiology reviews, med refills, patient emails, messages, call center, so forth. Anyway, the in basket is ruining primary care. Your thoughts on that?
I like the perspective, but I think you're wrong. When I was in private practice, I never looked at my mail. I never screened my mail. I had an office manager and an administrative assistant who looked at that and only got me the most important stuff. There's nothing that says that you have to handle your inbox alone, and there's nothing that states that you can't set limits on your inbox. So maybe what you have to do in your practice is establish workflows where the inbox is screened by members of your team-based care panel that can be assigned to these different issues. If a patient writes to you on your inbox that they need a refill for the prescription and you respond to it, I can tell you that's clearly a waste of time. So what we have to do is redesign our processes. We have to set limits. We have to train our staff how to interact with us, and we have to make sure that we train our patients as well. I often say that if you don't teach your patients anything, they basically do whatever they want. And one of my challenges during the course of my career is my patients refused to get sick on time. They got sick whenever they felt like it. I'm only kidding. But the bottom line is they really didn't know what to do. And in the early days of my practice, we never gave them any instruction. But the more instruction you provide for your patients, the more you reverberate those instructions through your MAs, through your nurses, through your front desk, they're going to know how to handle these problems and how to interact with you. When it comes to labs and everything else, my feeling is you shouldn't look at anything unless it's a critical value. And you should be able to set your inbox so that you don't have to waste your time looking at normal lab data. As far as getting back to patients with that lab data, if you have a good workflow, you can have a member of your staff do so. You don't have to get back to them. Now, I know what you're thinking. You're saying to yourself, well, I can't afford that. I don't have that extra money to hire that person. But what I'm telling you to do is if you hire that person, you're going to have the extra time to generate additional funds to be able to support more than that person. So it's up to you to define how you're going to spend your time. I understand it's burdensome. I hear this from multiple physicians, but it's up to us to change it. Next.
Very good points. Thanks. The next one has to do with the whole business aspect of medicine. Dr. Benzuela says, business or accounting 101 should be part of residency or medical school as an elective or required course. I graduated from residency when, I think this means when people didn't know, or I didn't know what an HMO stood for. So certainly following up on your recommendation for learning the business of medicine.
Well, actually, I fully agree with you, except for one thing. I don't think it should be an elective. I don't think there's any way to survive unless you can understand the business of healthcare. And frankly, and I'm not exaggerating when I say this, 9 out of 10 physicians cannot read a financial spreadsheet. And since we have so much pride and we have pretty substantial egos, and I'm one of them, so I can speak this way, we're afraid to say we don't understand what we're reading. So you go to a meeting, they present the financial information, you look at that spreadsheet, and you're afraid to say, I really don't get it. I don't understand the profit and loss statement. I don't understand the age trial balance. And in the Enhancing Health Leadership program that we teach, that I teach, I basically have an example of an age trial balance where on the top example, you can actually see that balance in 30, 60, 90 days and beyond that. In the second example, you see the exact same thing, but you see a slight shift in the early aspect of that age trial balance. And I ask physicians what the impact of that is. And 99% of the time, the physician looks at me and says, well, it looks like the same. You have the same amount of money out there. What they don't realize is if you're not collecting the money early on, that's a sign that there's something wrong in your system. And the longer it takes to catch it, the deeper trouble your practice is going to be in. So teaching physicians how to recognize some of those pitfalls and being able to look at some of these spreadsheets and being able to know whether or not you can really buy that new piece of equipment or whether or not you need a larger office or an office in another area is really key to this type of decision making. We're often good at looking at labs and looking at trajectories of health, but we're really not good at looking at it from a financial perspective. And I believe that if we make better financial judgments, we will also reduce burnout further. So thank you for that wonderful point.
Good points there, and thank you. Dr. Adams followed up, and I'll tell you what, I'll read this. I think you're, everyone's off mute, and feel free to speak up here, Dr. Adams. Let me just read this. In following up on the in-basket and so forth, the team-based solution. One of the problems with team-based care solutions is that the team will never be as invested in your patients like the physician is, whose license is on the line in delivering the care. At 5 p.m., the team goes home and the physician is left with an overflowing in-basket. And continuing on, keep in mind that most of us do not own our practices. We are employees of larger healthcare organizations, so we're at the mercy of our administrations. To say that we don't have to look at lab results or check our emails and messages just isn't realistic, with all due respect.
I understand your perspective, and with a great deal of respect, I disagree. I think that there's some great teams out there. I worked with a team this past month where 60 employees were basically brought together, 60 plus employees, 10 providers, and they committed themselves to a 6-month learning activity where they set up 6 teams with 6 projects. I know the group because I've trained a number of them in our Population Health Medical Academy, and I can tell you that the nurses, the NPs, the PAs, the counselors care as much about the patients as the doctors do. And they stay late, they come in early, they really look at this as their lifeline, not only to their patients, but their own success in life. And I can tell you that that level of dedication only occurs when you have the right leadership. I find that over the course of years, when you look at business and you look at healthcare, you find that the leaders who complain about the staff are often leaders who are not adept at what they're doing. But when you have a large organization that learns how to treat people well, that incentivizes the team, that basically provides the type of supports that they need, you will find that there are people that will jump in there and care as much, if not more, than the physicians. So every situation is different. I don't doubt that what you're saying exists. In fact, I believe that what you're saying probably exists more than what I'm projecting, but it doesn't have to be that way. So thank you for bringing up that excellent point. I want to bring something up. A lot of the suggestions that I've made this evening probably seem somewhat far-fetched for you. But I want you to know that we have a practice liaison for RCMA. Her name is Sandy Lozo. She is absolutely magnificent. If you are a member of RCMA and you want to learn how to do any of these things, and I don't mean through a lecture, but I mean for somebody coming to your office and working with you and your staff, and this is built into your RCMA membership, all you have to do is contact us. And I can tell you that her services are fabulous. If you have doubts, why not take the time to meet with her? And we will do everything we possibly can to help you reduce burnout and improve the enjoyment that you have from practicing medicine. And
thank you again. That is a great benefit. And, please take advantage of it for, RCMA has a lot to offer, and hopefully this will help you out. So thanks again, everyone. Have a good evening, and you take care now. Bye-bye.